Good evening, everyone. Thank you for starting your February with us, and this is your 75th AeHIN Hour. We are now using GoToWebinar. If you need assistance, please feel free to send us a message through the chat box so we can help you. If you are having difficulties in configuring your connection, please log out from the session and rejoin again. You may also use your smartphones or tablets to join by using the webinar ID 389-358-923. Before we start our webinar, here are a few reminders. For attendees, your microphones are muted throughout the meeting. You can chat your thoughts to us through the chat tab. And for questions, you can send them through the questions tab. All questions will be answered after the speaker's lecture. For tonight, we have with us Dr. Carl Leitner. Dr. Leitner brings more than 15 years of experience in informatics, information technology, software development, standards development, and education, including more than 8 years designing and adapting health information systems for use in low and middle-income countries. At present, he is the Deputy Director for Global Goods at PATH for the new Digital Health Initiative and will help to ensure high-quality standards-compliant, interoperable open-source health information tools. We now call in our speaker, Dr. Carl.
Good morning, everyone. Can you hear me okay?
Yes, we can hear you well. Thank you.
Okay, great. Thank you very much for this opportunity to participate in the AeHIN webinar. Today, I want to talk with you all about health worker directories and health worker registries. In particular, we're going to be looking at the IRIS software. The webinar today is going to be broken up into 3 different parts. The first part is on looking at IRIS software tools for management and planning of the health workforce. The second, we'll look at some examples of the use of IRIS and data use for human resources for health. And third, we're going to be looking at linking IRIS to other health information system components. So now we get started with the first part. IRIS is a software tool that was designed to work with health workforce information systems and to collect data on the health workforce. On the upper right hand of the screen, you'll see a typical human resource ledger that we were working with when we started the IRIS software about 10 years ago today. And in the middle on the right hand side, you'll see a screenshot of the IRIS Qualify software. And I should say that the IRIS software is an open source software using the GPL license. There's no ongoing license fees. And what we've seen is that multiple countries have adopted IRIS for use. And when one country wants a new module built, that country's module will then go back into the core IRIS software in order for other countries to benefit it as well. At present, there are about 25 countries that are using IRIS, and it contains around 1 million health worker records. The IRIS software was started by InterHealth International under the USAID-funded capacity project. We do a lot within the IRIS community to ensure that there is a large emphasis on capacity building and supporting the global community. We have support for the administration and use of IRIS coming from our global help desk, which includes a Google group, a Slack channel, and a wiki. We also work to ensure that users of IRIS are connected across countries, and to ensure sort of the long-term longevity of IRIS, we are starting at the moment the IRIS Foundation, which is going to focus on supporting the global IRIS community in core software development. And that is one of the things I will be doing in my new position at PATH. While I was at IntraHealth, I was one of the core Iris developers and responsible for ensuring the use of the Iris software. Um, we understand that Iris does not exist in isolation and that the data in Iris is useful for other parts of the health information system. And to that end, we support data standards, whether they are specific terminologies like the Isco International Standard and Classification of Occupations, the Isco codes to classify health workers, or WHO standards for health worker registries, as well as specific API and data exchange standards. In particular, we focus a lot on interoperability with DHIS2 and the OpenHIE initiative. Moving on, to understand the Iris software, it's good to understand the health workforce information lifecycle. What happens to a health worker as they move through the system? At the top, we start with their education and training. When they're in pre-service education, typically we would want to track what competencies the health worker has received, what are the certifications that they are receiving, what exams that they've passed. Once a health worker has completed their training, they go into registration with a professional counsel, whether that's a nursing council or a medical board. Once they've properly registered, they can be hired and deployed by the Ministry of Health or other health delivery network. And the needs to track the deployment information for a health worker are a bit different than the registration and training. Once they've been deployed, they are actively managed. They are supervised. They can receive disciplinary actions. We need to track their dependents and other information about the health worker. And finally, once we have all this information together, we can look at planning for future growth of the health workforce. Do we have the correct health workers in the right place at the right time? Do we need to reallocate health workers? So looking at all of this type of information that's related to the health worker as they go through the workforce, we see that there's a need for different types of software to answer questions relating to the different parts of the health worker lifecycle. And so those tools that we've developed, there are 5 main tools, and there's some for the health workforce management and planning. So the first one is Iris Manage. That's a typical HR management software that would be used by a health delivery network, such as a Ministry of Health, to manage their health workforce. So we track the deployment of the health worker, who their supervisor is, any in-service and pre-service trainings they might have received. But that's your typical starting point for a Ministry of Health. The next is Iris Qualify, which is designed for professional councils like a medical council or a nursing board. This is used to track and manage information about all of the health workers within that professional council. So you might have an Iris Qualify for a nursing council. When a health worker comes in, they become registered with the council. They verify that they passed their exams and have paid their registration fees in order to obtain a license. Iris Plan is a health workforce planning tool. It's used to model and project the supply and demand of health workers over time based on things like new hiring policies, graduation rates, retirement planning. Iris Retain is designed as a costing tool to cost various interventions to retain health workers, in particular for rural areas. Provides a tool to collect a basket of interventions and cost them out for a large health workforce intervention. And finally, we have Iris Train, which is a in-service as well as pre-service training management system. It's used to track trainings, whether they're pre-service or in-service, for health workers across multiple training organizations, and to create a system where various organizations can provide the training information to the Ministry of Health. This can help to reduce things such as repeated health worker trainings for the same health worker that are inappropriate, because you have a central mechanism to try to track the trainings that were being offered to the health worker. So of these 5 pieces of software, the Iris Manage, Iris Qualify, and Iris Train, they all have, they're all sources of health worker information. So we will call these health worker directories. One is for HR management, one is for the professional councils, and one is for training. To give you a sense of what are some of the management modules that are in Iris, we have a module to track the dependents, to track workplace incidents and accidents, disciplinary actions, uploads of photos, resumes, the creation of form letters and license cards, tracking the establishment of the or staffing norms of the health workforce, and to see who's actually deployed according to the establishment, tracking of probationary periods, the ability to archive scanned paper records and generated reports, as well as track next of kin information. This is just a sample of the type of functionality that you'll find in the Iris software. One thing that you'll note that's missing here are payroll systems and time and attendance. Iris Manage hasn't particularly been designed as a payroll software. Instead, we would link or interface with a Ministry of Finance or other payroll system and pull that information into Iris. Here you can see a screenshot of the Iris Qualify database for the Nursing and Midwifery Council of Nigeria, which has around 250,000 records for nurses in Nigeria. So we can scale to quite a large pool of health workers. Next, you see Iris Manage for the Ministry of Health in Mali, and you can see that we have support for translations of Iris to multiple languages. We have around 7 or 8 languages, mostly fully translated for Iris. Now we're going to look at a few examples of how countries have used the data in Iris to answer key HRH questions. One here is a the use of Iris in Zanzibar. So you can see in the upper left a picture of the original HR information system, the paper records that were being used by the Ministry of Health in Zanzibar. So you can imagine if you were trying to figure out how many nurses are working in all of your clinics, going through all of those papers, files and folders, and counting and collating could be very time-consuming and impractical. They went through the process of digitizing their records and uploading them into Iris, and can easily produce graphs and reports. In the bottom left, you see a graph of the distribution of the health workers on the 2 islands of Zanzibar, Pemba, and Unguja, and by the health worker cadre. The Ministry of Health was able to use the data in Iris to show that they had a deficit of health workers, and they were able to use that to argue and receive additional funding for hiring new health workers. So just having the data and having the information to be able to make those arguments with data to back it was really helped the Ministry of Health of Zanzibar improve the service quality. Next, we look at some data that came out of the use of IRIS in Kenya, where it's been deployed at the national level and decentralized to the county. Here, we're looking at gender issues in particular that the IRIS data highlighted. On the bottom right, you'll see that there's a difference in the average years to promotion for male and female. I'm sorry that the female is color-coded brown instead of blue, but you can see that there is a discrepancy in the average years to promotions based on gender, which suggests that an intervention might be made at the policy level to address some of those issues and to ensure equitable health workforce. On the left-hand side, you see that for the nurses and midwives that there's not an equal distribution across the genders. So 3 out of 4 nurses and midwives are female, which suggests that there's a population of potential male health workers that could be used to alleviate some of the healthcare worker shortages in Kenya. Next, we look at Uganda, and it was used by the allied health professionals of Uganda. This is IRIS Qualify. On the left-hand side, you see a graph of the license renewals from 2001 on. It was between 2007 and 2008 when they started using IRIS Qualify. And one of the reasons why they have such an increase in the number of health professionals being licensed is they started a quack doctors program where you could send an SMS to a central number that with the name of a doctor. The doctor's name would be looked up against the IRIS database, and people could confirm that the doctor was indeed a legitimate doctor. And they could only be confirmed if they had their license and registration up to date in IRIS Qualify. So here we see a policy decision and a citizen access to the data really drove up the registration rates for the Allied Health Professionals Council, which generated more revenue for the professional council, so it has more autonomy from the Ministry of Health, but B, also ensures that we have a valid supply of qualified health workers providing services in Uganda. And for the third part, just like to talk about linking IRIS to other parts of the health information system. So to understand where the data that is coming from IRIS, we've got lots of sources of data. So at the top in the purple, we can see that we have the professional councils. So that's, for example, using IRIS Qualify. They have a source of data that we want. A source of data, and that data we want to feed it into a national health worker registry. Okay, so the National Health Worker Registry is going to consolidate the information across the councils to produce a national picture across the councils of the available health workforce. On the upper right, we have the training institutions that are providing pre-service and in-service training for health workers. We also want that to feed into the National Health Worker Registry. So we've got a more complete picture of the health worker. On the left-hand side, we have the Ministry of Health, that is usually the largest service delivery network in many countries. If they're using something like IRIS Manage, they'll have the information about the deployment information. They'll be the authority for where health workers are located. as well as the Ministry of Health, we also, in some countries, have local government or Ministry of Local Governance that is responsible at the county or district level for managing all the public sector workforce. So between the Ministry of Health and the local governments, you generally have the public sector workforce. And we want all of that information to feed into the National Health Worker Registry to combine with the licensure data from the professional councils, the training data from the training institutions, and then on the right-hand side in orange, we see the non-public sector workforce. So this might be a faith-based organization providing services. This might be an NGO that has health workers that they are deploying, as well as for-profit or private sector. All of these will have their own HR information systems, and regardless of whether it's IRIS or some other HR information system, we want to be able to pull that data into that National Health Worker Registry so we have a complete picture of the health workforce. Once we have the consolidated picture, we can really think about sharing the data across to other systems, whether they be e-health systems like electronic medical record systems at a facility, or an m-health system used by a community health worker, knowing that where the health workers are, we can use that information to populate the users in the e-health and m-health systems. Additionally, if we are a country is deploying a shared health record or longitudinal health record, they can validate the data that goes into the health record against the health worker registry to ensure that that we have a valid health worker provider that was interacting with the client. If we look at some of the standards that are available, I've already mentioned the Isco standards for classifying health workers. That's sort of a data dictionary, if you will. We also have different data models for capturing the data and exchanging out the data. A few of them are listed here. Just want to focus on the Care Services Discovery Standard, which is the one, the CSD standard. That's the one that's currently being used by OpenHIE, and IRIS is for its health worker registry, and IRIS is fully compliant with that CSD standard. Just also to note, there's some work in progress to update that CSD standard to be compatible with something called HL7 Fire, and that's going to be published in August, and we'll of course update the IRIS and the health worker registry software to meet those standards. And if we look at the role that IRIS and the health worker registry plays in OpenHIE, you'll see on the left-hand side the OpenHIE architectural diagram. I don't necessarily want to go into much detail at this moment, but you'll see in the upper right-hand part of that gray diagram where it says HWR. That's our health worker registry. And the context that we've been talking about, that health worker registry is being fed by things like IRIS Manage, IRIS Qualify, and IRIS Train. Once that data is in that health worker registry, we can link it to other parts of the health information system quite readily, whether it's through the HMIS system like DHIS2 or the facility registry to ensure that we have the correct references for the health facility of the health worker, or whether it's being used by the external systems, the data in there. And finally, once we have all of this data in the health worker registry and compliant OpenHIE, we can start to build new applications on top of that. For example, there's something called mHero, which takes the data from the health worker registry. It links it to something called Rapid Pro, which is a UNICEF-funded SMS platform to create a health worker communication infrastructure. So it allows the Ministry of Health to communicate with all health workers via SMS at a central place based on the data that they're managing in their Iris managed system. And I think I will stop here and open it up to questions. Thank you very much.
Yes, thank you for that lecture, Dr. Carl. We have some questions here. The first one is from Dr. Alvin Marcelo. He is asking, if a country Ministry of Health wants to test iris, what should they do?
Okay, sure. So there's a couple of different options. One is there's an online demo for the the software components Iris Manage, Iris Qualify, and I'm happy to share a link out to those demos after this webinar. So just to get a very quick overview what Iris looks like, you can go to those demos. The next step is you're getting a bit more serious about it, and you want to install one of the demos on your own servers. We have Iris packaged up for the Ubuntu Linux distribution. I believe right now we have 14.04 and 16.04, and there's some very easy installation tools for Iris there. So those we'll send some more links and to information on how to do that. And I think the third thing that I would suggest doing is to contact the global Iris community and let them know that you're interested in, so that you have a connection to the community. If you run into any issues or questions about its use, you have that. And for that, we have our Google group as well as a Slack channel. The Google group is for an email listserv. The Slack channel is for more real-time question and answer. So I'll make sure all of those resources are shared out.
Yes, thank you, Dr. Carl. Here is another question from Dr. Alvin and Dr. Bunchai, who's in the webinar room now. Is Iris compliant with OpenHIE architecture?
Yes, of course it is. So as I mentioned, right now we are using the CSD standard for OpenHIE, and Iris is compliant with that, and we'll be moving to the more modern RESTful HL7 FHIR standard. And that is coming through the IHE, integrating the Health Enterprise Standards Development Organization. Luke Duncan, who's one of the core Iris developers, is leading the development of the update to the CSD standard. If anybody is interested in what that looks like or participating in that process, we'll make sure that you get connected to Luke and can review the current draft of that. So please let us know if you're interested. We want to make sure that this updated standard catches everybody's use cases.
Yes, thank you. Another question is, what support can the Ministry of Health obtain from Iris developers, ranging from free to fee for service?
Sure. So for the free service, what we've done with the Iris Foundation is to establish that Iris Global Help Desk. And the intention of that is for countries that perhaps don't have any funding or projects or any way to support an Iris installation or maintain that. And so we offer some moderate amount of help desk support with that. And that's free. The other opportunity for free help is, of course, the Google group and the Slack channel. And there you'll find quite a large number of interested Iris developers across the 24 countries that Iris is deployed in. Some of those are consultants that could be hired by a ministry. And they will often offer their help for free for some of the basic questions about Iris. And then finally, if you're looking for a more engaged um, software development, there are multiple organizations that support Iris. IntraHealth is the international is the organization that it has the majority of the Iris development being done. So I would recommend contacting IntraHealth International, and I'd be happy to make sure that you have the correct contacts for that, for a more engaged service contractor or other um, uh, extended support.
Yes, thank you. Here's another question. This one is from Dr. Praveen Shakya. Dr. Praveen is asking, can we implement IRIS in non-government institutions like academic hospitals?
Sure. So Iris, has been um, designed primarily for the Ministry of Health, but we also use it for non-Ministry of Health. So you just wouldn't use certain features and functionalities within a hospital. Um, so, I think it just really depends on as to what you want to do with that information, and to ensure that you're getting the information that you need. If there's some modules that are missing, then we can um, discuss ways that those could be developed. But we've certainly have seen Iris used in sort of private sector or non-governmental institutions. I know, for example, in Botswana, they used it in a number of private sector hospitals, particularly the mining corporations have their own hospitals that they run. Um, and I don't know if that's answering your question or if you have any specific things that you wanted to ask about that, but I'm happy to follow up.
All right. Our next question is from Dr. Sambat. It reads, IRIS is linked to electronic medical record to track doctor who treat patients and follow up.
Uh, which, okay, yeah. Yeah, so the whole point of the OpenHIE project, and I wish I had prepared the slide. So there is an OpenHIE workflow for saving data to the shared health record, or the SHR that's in this diagram that you see up on the screen. And so what happens is, let's say we have a hospital that sends something like an HL7 message or into the OpenHIE Health Information Exchange. That message hits the interoperability layer. At the interoperability layer, that message is pulled apart and the facility is validated. The health worker is validated against the health worker registry. And any terminologies are checked against the terminology service, the client is checked against the client registry, and all of that happens before the data is sent to the shared health record. There are no number of countries that are using that workflow. It's the Safe Patient Encounter workflow if you go on the OpenHIE website. And so yes, the IRIS data is put into the health worker registry where it can be used to validate that record. In terms of the follow-up, to be honest, a lot of the countries that we're working in with IRIS, they don't have a very mature EMR deployment. And so we're really only beginning to address some of these issues about follow-up across multiple EMR systems. And that's where OpenHIE would play more of a role. If we're really working only in one facility, I don't think you typically would have one EMR in the facility, or hopefully only one EMR in the facility, and that type of follow-up could probably be handled within that one EMR, but the use is more the multiple facility. I think you also had another question. about does Iris connect with OpenHIE? Does it work in practice or just theory in my slide? It's very much working in practice. So this slide, for example, mHero has been deployed in Mali, Guinea, Sierra Leone, Liberia, and Tanzania. So it's definitely is working. It's not just a theory.
Yes, thank you, Dr. Carl. If for our participants, if you still have questions, please type them in now. We'll be waiting for your questions.
And if I didn't answer your question thoroughly enough, please let me know and I can re-answer.
Hey Carl, this is Alvin.
Hi, Alvin. How are you?
Hey Carl, I'm with Dr. Bunchay. We're actually in the downtown Bangkok right now. And I was interested in the EMR connection because right now we have 1,000 EMRs in frontline clinics in the Philippines. And each of those EMRs have a user list, right? They're
Mm-hmm.
actually, so can that user list synchronize now with Iris through an OpenHIE architecture so that we actually know which ones are using which EMRs in which parts of the country, which can be monitored for human resource performance. Over.
Sure. Yeah. So the idea here is that for each of those frontline EMRs, you have the users are health workers. And so you have two options. One is, okay, we're doing a new installation of an EMR. We know who the health workers are deployed from IRIS or the health worker registry, and we can use that to pre-populate the EMRs. But you're talking more about the existing EMRs. But in either case, what I would recommend doing is that the EMRs export their data according to the CSD or the updated version of CSD standard that's coming out, which includes the basic demographic information, the name and family name and given name for the health worker. You would have some sense of the user role from the EMR, which may or may not be tied to their cadre. But most importantly, you would have one or more identifiers for that health worker. In particular, you would have the internal ID used by the EMR to track that user. So that internal ID for the EMR, that's data that we would want to extract from the EMR, put it into the health worker registry associated with the other information from the other systems populating the health worker registry, so that you have all of the internal IDs across the EMRs for that health worker.
Thanks, Carl. So just to let you know, we will be installing Iris in the AeHIN lab.
Okay.
I've assigned Randy Fernandez, who's a engineer, to take on that role. Maybe he will work with you and look on the installation. And then one specific project would be connecting those 1,000 EMRs to that installation and then
Okay.
demonstrating it to the ministry once we've done the connection.
Well, that's quite exciting.
Yep. Thanks, Carl. And let's
Thank you.
talk about it more in detail. Maybe we can do a prototyping between now and Myanmar. And then when we're in Myanmar, I'll bring the vice minister and show the iris that we've populated.
Okay.
Let's try to do that and take advantage of the presence of our vice minister there.
Okay. No, that
Over.
sounds like a
Good.
opportunity.
Yes. Charisse, any more questions over there?
No more, Dr. Alvin. Okay, so if there are no more questions, we would like to wrap up this
Yes.
session.
So
Yes,
I'd like to thank Carl Leitner for the time he gave us tonight. Carl, thank you very much. We'll send more communications offline by email, and then I'll pass on the mic to Chat for the goodbye messages. Go ahead, Chat.
yes, we would like to also invite everyone for our upcoming webinar on February 8th at 4 p.m. Manila time. We hope our attendees can come again. And thank you for your time and expertise, Dr. Carl, and thank you for all our participants who actively participated in the session.
Thank you for the opportunity, everyone, and it was a pleasure chatting with you.